light in this paper. So we chose to look at fidelity. Is something I got kind of tuned into when I was working on a paper with Chad Cook and some other folks surrounding knee osteoarthritis. And we applied some of the fidelity tools that have been used more in psychology literature to that paper. And I found it interesting because it looks at things totally different than maybe like quality or risk of bias, or just looking at, was this treatment effective, but how did they go about it? You know, how did all that go down? And I think that's what fidelity to me looks at, is, you know, not just the methodology, but supposed to be was done in an appropriate manner, and the same person did it. And people were thinking, you know, wasn't that quality? Isn't that risk of bias? Isn't that methodology? Well, it's not really captured in any of that. And if you look at the pieces of fidelity we chose to use, I think it makes sense for intervention studies.
I don't know if Derek caught this or what your thoughts are, Paul, but the fidelity measure y'all used is, as you said, like from psychology literature, but I know
Right.
It said that it hasn't been validated. And I thought that was just kind of funny because it's like, this is it seems like you're looking at some of the like validity of KT tape using like a fidelity measurement, but the fidelity measurement itself hasn't been validated.
Exactly. Yeah. So, I mean, and that's I think certainly a limitation, because we pulled the pieces from that tool that could be applied to our profession, right? That kind of fit into PT, but it hasn't been validated. But I think we were transparent about that and said, hey, this hasn't been validated, but here, or at least, I mean, even if we're not putting a number to it. We're not saying, this number is this or this number is that. I think we did. That may not have been the best way to do that. But, we were transparent that it hadn't been validated. And I think even at face value, just looking at some of the questions that are asked and saying yes or no, did they do that, kind of can tell you a little bit more about that paper, even if it hasn't been validated. It's like, is the grass green? Well, no, that grass is kind of brown, so maybe it's dry. Well, I haven't really validated that, but I can look at it and say that the grass is brown, and I can indicate probably from seeing that it might be in need of some water. So yeah, I get that, and I'm all about that, and I think that is a limitation. So you have to be careful what to take away from that. But I think it's something that's getting more attention lately, is fidelity of particular intervention studies.
Yeah. I was also curious of it mentioned, you all talked about in the introduction, where a lot of these reviews of KT tape has been on comparing it as like a stole intervention, I believe, and how there's been kind of mixed results, but this paper or this review was trying to look at it from like a clinical perspective of how it actually be utilized with other treatments. And I know, at least like from some of the stuff, like reading Eric Mira's stuff or listening to his talk, he talks a lot about like the downside of like an A compared to A plus B intervention or a study. Does that, like, was there any downsides to looking at the like efficacy of something when it's not just that thing? Because I feel like there's way more confounders when you're adding on other things and then comparing it.
Absolutely. So you're right. So that where you look at, I would say, internal versus external validity of something, right? Like in a closed environment. I don't know if you can still. Can
Cutting in
you all
and
hear
out.
me?
I heard
Oh.
in a closed environment.
Yeah. Okay. So I think you can look at both of those, and I think both ways have merit, right? I think looking at something in isolation and seeing how it's effective is great. That to me is kind of like, all right, we're going to set this up in a lab. We're going to see how somebody responds to this, and we'll go from there and we'll determine that. But that oftentimes isn't how it's done in the real world. So, you know, when you do an intervention, there's oftentimes a lot of other things going on. And the papers had already been written looking at KT tape by itself compared to something else. And so we wanted to highlight more about how it's actually utilized in clinic. But you're right, you do get those other variables that are really hard to control for, and may not be the most clean way to look at things, but it's also probably the most realistic way to look at things. So it's kind of like your internal and external validity in any kind of, the cleanest methods may not be the most applicable, and the most applicable may not be the cleanest method. So we try as researchers to do our best to find a middle ground, but at the end of the day, the clinic is where stuff happens. So we need to be heading in that direction somehow, to see what the effectiveness of an intervention is.
Yeah. That makes sense. And going off that, I know there's a quote, I think it was in the discussion, and it was just like a part of a sentence that essentially clinical practice often dictates multimodal approaches to care, kind of hinting at the fact that most clinicians aren't going to just do one treatment. And I've heard this. So in our program last year, we had like debates, and it would compare like treatment X versus treatment X. And sometimes it was like exercise compared to, or discussion against exercise plus like manual therapy or whatever. And at the end of the like debate, the chair of our department would be like, yeah, both sides aren't wrong. Like you're probably going to have a multimodal approach. And to me, that felt like a very like cop-outy answer. Like, let's just throw shit at the wall and see what sticks. What are your thoughts on like the concept of like a multimodal approach to care, or the idea of like, well, it doesn't hurt to try multiple things. Like, what's the downside?
Yeah, I think you have to look at your definition of multimodal approach, right? Because I would argue that any therapist worth their salt, well, I'd be careful how I say this. I think anybody who's invested in a patient and getting them better, I'll use myself as an example. If let's just say I think I want to do one thing, maybe it's exercise, right? Inevitably, after my evaluation, we're going to sit down and we're going to have a shared decision-making conversation where I point out the options, talk about the evidence, and we're going to come up with the best value-based care for that patient, whatever it looks like. And no treatment is always an option, right? It has to be. And we put everything out on the table. And so then I continue to educate the patient about whatever. And then we start in on maybe some strength and conditioning stuff, and I want to get them stronger. I want to change this type of pattern, whatever. But I'm thinking it's strength and conditioning. Well, I've also used education in there too. So that's kind of a multimodal approach, because I educated them about maybe activity modification, or I educated them about managing their pain at home or positioning. And then I did a strength and conditioning piece. So I might think, well, I'm just doing strength and conditioning. That's all I'm doing. I'm not going to do K-tape or ultrasound or any other biophysical agents, because I don't believe in that stuff. But in a sense, you're almost always using a multimodal approach with a patient, even if you think you're sticking with one intervention, in my mind. And so I think it depends on how you define that. So just to kind of be upfront with this, my thoughts about K-tape I mean, even before starting this, and that's where I had to check myself at the door, is that, I don't think it's high value based care. I don't. That doesn't mean to say that there isn't some value to it, or that the right population can't benefit from it, or it doesn't have its place. But for me, it's not something I would go to in my clinic very readily when I saw patients. It wouldn't be an intervention that I would go, because I put other things sort of in a category, I don't want to say above that, but that I would feel comfortable going to first. And that's not to say people who use it shouldn't be using it, or patients shouldn't get it. That was just my bias. And so I made sure, both with my team and with our approach, that didn't get kind of caught up, and we let the evidence sort of do the talking with what we were trying to do.
Yeah. So if a patient comes in with shoulder pain, and let's say you have things that you would prioritize over it, but then a patient asks, well, do you think this is something that would benefit me, or would you be able to do this? Would there be hesitancy, or would it be like, well, if we like attack these other, maybe higher value things, like you said, I don't have an issue with giving this to you, or you getting it somewhere else? Is that what the conversation would look like, or how would that go?
That's a tough one. I think that's hard to say without knowing how the conversation goes ahead of time. And I think that's where I don't want to say I try and cut it off at the pass, because that's not the point of having that shared decision-making conversation. But essentially, you're putting all the options out there with current evidence, including no treatment being an option, and then the patient makes the choice about their care, right? I mean, that's, at the end of the day, that's what shared decision, and I like that model, and I think that's good. That's not to say that I ignore what evidence-based medicine is, and that consists of three things, right? That consists of my experience as a clinician, what the experiences and the values of the patient brings to the table, and then the evidence that we think of as research, right? And I can't set one of those in my own head as a higher priority than another. I've got to bring them all together collectively for the benefit of the patient. So if the patient has had a certain treatment that's worked for them in the past, and they think that's great, and my clinical experience doesn't jive with that, and the evidence maybe doesn't jive with that, well, then I got to blend somehow that conversation to say, hey, you know what? That worked in the past for you. I think that's a potential option. Let's try X, Y, and Z, and you could say, some people might say, well, I'll throw in there that, yeah, you had that before, but you're back again, right? So it must not have worked. I don't want to do that. I don't want to put a negative connotation on another therapist or a treatment, but I also want to be very transparent about what value-based care is, and not try and sell them snake oil, even if they really want snake oil. You know what I mean? So it's a real tight rope to walk, but I think you can set yourself up well by having that shared decision-making conversation, and then kind of see where things line up. But I'm not, and that's one of the reasons I got out of, high-level sports and dealing with high-level athletes, because that's an environment where you just give them what they want in most cases. Like, I want this, I want that, and that's what they think they need, and they get it, and that's great. And in a sense, maybe that is what they need at that point, if that's what they think they need. I mean, that's a whole philosophical debate we can get into. Aside from that, so I'm not saying that's not what they need. Yeah, you got to be careful with that conversation. I think you never want to dismiss or disregard what the patient's bringing to the table, but you also don't.
Were you there?
I'm here.
You said, I missed the last part. You don't want to disregard what the patient's saying, but then
you also don't want to disregard your own experience and the evidence either. I mean, it's it's a really tricky thing that I think even with experience, the thing that constantly changes is everything. Your experience changes, the next patient changes, and the evidence changes if you allow it to, right? If you allow it to. I think we can get stuck in our own heads that, you know, my experience is my experience, and the evidence, I'll never bother to look at anything past the 10 years ago when I went to PT school, and I'm not open to new ideas. Well, then the evidence doesn't change if you don't look at it. So
do you think that it becomes even more challenging? Because, I mean, you're right, we don't want to like invalidate or not listen to what they're coming in and telling us. So like, I just started clinic this week, and already we had a patient came in who thinks, you know, my hips are out of whack, I got an adjustment, it feels great. And it's like, you know, you respect what they said, but at the same time, you know, deep down, like, that's not how your anatomy works, and that's not the effect of an adjustment. But at the same time, if they found relief and found that that's, you know, important, the other side of it is, well, I don't know how many times I'm going to see this person and how much time I'm going to have to actually build a rapport to really like dive in and address a lot of this like misconception or no CBIC language. So how do you kind of like unpack things to get more to that like evidence-based side and your experience, let's say like in the K-tape situation where you have an athlete come in who says, no, the K-tape, you know, made a lot of difference, it really helped. And you're thinking, well, that's a potential, but probably not for the reasons that you think. But you may only see this person 3 or 4 times, and you don't want to look at them and say, nah, that's not how this works, and potentially ruin that relationship. But you also don't want to just give in and be like, okay, well, we'll do the, you know, the K-tape and these other things. Like, how do you kind of navigate that with a situation like that?
yeah, I don't know that it gets any harder than that situation you just described with, you know, stuff's out of whack, I got adjusted, everything's back in its place now, and I feel great. And they're 65 years old, you know, their SIJ and everything else is fused. Even if it wasn't, it moves like point some millimeters to begin with. So, you know all that, and all they know is that my hips were out of whack, I got adjusted, and I feel so much better. Now, if there's any more evidence for the art of our profession, it's in how to deal with that, right? The other piece is easy. And so, and I don't think there's an easy way to deal with that. I think that's challenging even for a seasoned clinician, to figure out how to deal with that and get a read on the patient. How do I build rapport on the first visit that may be visit 1 of 2 or 1 of 3, you know, what's best for the patient? And how do I remove myself and my biases enough from the conversation, but not so much that I do them a disservice based on what I know. And golly, that's tough. That is really, really tough. So I think for me, and I don't know if this is right or wrong, is I'll validate, you know, I'll say I'm really glad you're feeling better, or I'm really glad that K-tape worked for you. And that may be something that we look at down the road. What we're beginning to understand now is that, you know, the body works, and maybe this isn't a first day conversation, right? But I really tread lightly on, you know, well, maybe now this is how we're understanding things. And so there may be other reasons why that was effective for you. And it's not to say that it might not be effective again, but we're going to try some other things in addition to that, or we're going to try some other things first. Yeah, golly, I would have a real hard time with that example you provided on like day 1, performing quote unquote some adjustment for them. That just doesn't sit great with me. And I don't know, that's probably wrong, right? That's probably wrong of me for it not to sit great with me, but that's just feeding into this whole thing that I'm trying to do my best from a research and clinician standpoint to fight, right? And so how am I going to be part of that problem while I'm trying to be part of the solution? That doesn't make any sense. But I've also got to realize that I'm ultimately there for the patient. So what's going to be best for them? Yeah. I know that's not really an answer to your question. It further convolutes things. But I think, man, if you get the answer to that, that's great. I think you got to take it on an individual basis. And some folks you're going to be successful with, and some folks you're not. Stick to your guns to a little bit, but don't get too overzealous would be my advice if I can give it. I don't think I can, but that's what I would say.
Yeah, because I mean, like the initial approach that I had, and granted, I mean, it was my first week in clinic, so I'm pretty raw at this, but they mentioned all of these things, and then kind of on the flip, like my thought was, first kind of asking them, well, A, what are you hoping to get out of this session? And B, like ultimately, what are you hoping to get back to, or what are the things that you enjoy? And when it came down to more like physical activity that they wanted to get back to, then for me, it was more of like, they kind of opened the door to expressing that like activity-based treatments would probably get them back more effectively or quicker, as long as like I was able to find things that they enjoyed and they wanted to do and didn't like overburden them. So it was, like walking and weightlifting were two things that he really wanted to get back to. So it was like, slowly kind of starting to discuss more of like building that capacity, and that, there is an open area for potentially providing more of like the hands-on stuff, but that it may not necessarily help him reach like that physical fitness aspect of what he's trying to get to. Again, I mean, that was just one case. So for him, I think it resonated, but it may not work like that for other people who are hell-bent that, no, my hips are out of whack and you need to put them back. So like you said, it's going to be different with everybody.
Yeah. I think that approach is phenomenal, because, you're at the end of the day, you're obviously you're listening to the patient, but you're taking their priorities and making them your priority without even really having to navigate that piece of it. I guess another avenue could be with some of these is that, it might provide temporary relief, but the long-term solution is going to be X, Y, and Z, according to my experience and the evidence and that sort of thing. So I think that's another thing that some people pull out of their back pocket too, is kind of the short-term versus long-term relief. But then again, you're also going to buy into that it is effective, and maybe it is for them. So, but I like that, because what you did is you cut them off of the past before you could even get to that point of conversation. So that's great.
And to give some background to Derek, I mean, he's in Chiro school and you're in student clinic right now, right?
Yeah.
Where you have like an overseeing clinician that I'm sure does things differently than what you'd hope. And
she's, if I remember correctly, she's got 23 years of experience, heavily influenced with treating like pediatrics. So already for me, I'm like, nope. And heavily bases her treatment off of like more of the dogmatic chiropractic. So the listings and like bones actually being out of place and realigning. So I'm already kind of at that like negative crossroad and disadvantage, but she did express that she's open to at least like talking and learning a little bit. But the other hard part is, because we have such a big class, every encounter that we have is a primary and a secondary. So another student's in there like taking notes and wanting to voice their opinion. And and many of them, like, we don't see eye to eye, because a lot of them just aren't heavily influenced by the evidence. It's everything I learned in school is fact, or it's not fact at all, kind of an approach. So
gotcha. That's
so
tough.
it's a little challenging. Yeah. And trying not to intervene with what the other student is doing is the primary, when you're like, maybe this isn't the best approach. But again, it's like, I'm not the primary clinician in the room. So
Right.
there's definitely lines that you don't want to cross, but everybody's gone through it.
Yeah. Keep fighting the good fight. Just don't die on that hill. That's all I got to say. So,
are you practicing out of University of Indianapolis, like their outpatient clinic, or where are you see patients?
So I was doing patient care in IU, so Indiana University healthcare system. Within the past several months, I've stopped that. And now my patient interaction is mainly with regards to research and not carrying a caseload.
Got it. Do you miss being in clinic, or are you stoked to do more just straight research?
Well, yeah, for the longest time, I didn't know how to sit with that in my gut because I always thought, how in the world can someone stand up and tell me what to do with patients if they haven't seen a patient in 5 or 10 years, right? That just seemed kind of not right to me as a student and as an early faculty member. I just thought you had to have your plans in clinic. And then I remember, I think back to Duke, and a lot of my professors there weren't seeing patients on a regular basis, and people who are doing high level research aren't, and are they in front of the class? And so I was like, man, I can't leave clinic, as much of a drain as it on me, to try and keep a caseload and do the research I'm doing and teach. It was a lot. And then I finally just said, I think it's time for me to get out of seeing patients on a regular basis and do some more meaningful research, because that's where my passion is. And then, I realized Coach K is one of my mentors, and I look up to him a lot. And I thought, well, Coach K hasn't played a basketball game in how many years, but damn if he can't coach the game really well. So maybe I don't have to be in clinic all the time with a caseload to be able to do what I need to do. And maybe I'm not doing my students a disservice by not carrying a caseload. So that's kind of how I rationalize it in my head. I don't know if that's right or wrong, but yeah.
Yeah, I got it. What, this is a side question, then I want to get back to the paper. What current studies are you working with right now? Or what type of projects?
Way too many. Probably the bigger one we're starting to get underway is with frozen shoulder, working with an orthopedic surgeon in his clinic and in the operating room, where we're looking at psychosocial factors that may influence frozen shoulder based off of some of Louise Holman's work, where she had those 5 individuals that were diagnosed with frozen shoulder, and then they put them under anesthesia just before doing a capsular release and looked at their range of motion. And what do you know? 3 of the 5 individuals had significantly greater range of motion before any procedure, but after anesthesia, leading some people to believe that there's more of a psychosocial guarding, or they don't want to move their shoulder, or it's something more than a structural component that's limiting their range. So he and I, the surgeon and I are taking a large inventory of these individuals coming in to see him for first time for frozen shoulder. We'll follow them along, whether they do well with conservative treatment or not. And then the ones that do receive surgery, we're gonna put them under anesthesia, take their measurements before the procedure and compare them and see if we can't get some predictive factors that we took before that might say, hey, when you see this first patient, if their fear avoidance or this or that, is this level, maybe it's not a true frozen shoulder. Maybe too many people are getting surgery that they don't need, and they need other interventions. So that's, I should also say that I'm working with Jeremy Lewis and Rachel Chester on that as well. So they're guiding me along on that study. So I'm really stoked about that. We're just trying to push the IRB through now, but yeah.
That's gonna be the jet. So when I was at the orthopedic rotation, one of the first patients that I did an eval on, she was diagnosed with frozen shoulder by a physician. She came in and had very typical presentation of a frozen shoulder. And this was a learning lesson for me, but we kind of talked about, potentially what it means. And also she had just had I think it was a left hip or left knee arthroplasty, or maybe a right. But she was also kind of rehabbing with that. And then she was in the process of moving. She was a 45, 50-year-old female with multiple kids moving to a different state. So there's all these factors in play. She's super stressed with work, moving to across the country. And I think the eval was on a Friday. And we gave her, I think, a few things to do at home, just some simple stretching and range of motion. And then she came back on, I think, Monday. And I asked how she was feeling. She's like, oh, I'm just a little bummed that, the pain is still there. This hasn't gone away. And we ended up having to sit down and tell her that, like the kind of natural process of this condition may take months to a year plus. And just like her face and that realization, and not really like hearing that from the physician, or from the physician who initially told her, and then from us on day one, but hearing it like later on would just like look like she was hit by a wall, because that's a really hard thing to grasp. But there came a point for me where I was thinking, like, is what I'm going to do in clinic even going to be beneficial for her? Like, she has all these other stressors and things in her life. She also has some other like health conditions, hypertensive, overweight, just had a knee arthroplasty. Like, what am I going to do in clinic that's going to, be of benefit to this healing process of the shoulder, or not even healing process, but recovery time. And so we spent most of the rehab talking about like, okay, we can potentially do some things to not decondition your arm in ranges that it can handle and work on the other side, but we can also really work on the recovery process or rehab process of your knee and your lower extremities, and just like kind of focused it more on a total, body conditioning, and not just focusing on the shoulder. But she ended up leaving like a month later because she moved. And I was just like, I'm curious to hear your thoughts. What do you think clinicians have any impact on frozen shoulder, or is it just, it's going to take a long time, and really we're not really speeding up the process?
I think we can. I think we don't know enough about it at this point, to be honest with you. It's been a little over 100 years since frozen shoulder was first described, and I don't think that we know any more about it, well, as much as we'd like to think we know about it currently. I think we have more questions now than we did when it probably was first described, because it's currently a diagnosis of exclusion, right? So you rule out, osteoarthritis, malignancies, you rule out, posterior dislocation, you rule out all these other things that aren't big and scary, and the shoulder is stiff and, lacks range of motion in all planes, then it's a frozen shoulder. That's probably not the best way to go about creating diagnosis. And as we're trying to uncover, I think there's a lot of other factors that play into it. There's people who probably have some sort of true restriction, and there's some people who are not moving their shoulder for other reasons. And so if we don't even know why it's presenting the way it is, it makes it really hard to try and come up with the most effective treatment approach. So if we're throwing the same thing at frozen shoulder when there's different etiologies, it's going to look like we don't know what we're doing, and the outcomes are going to be such. And I think that's what they are. So I think in the right hands and trying to understand all the variables that may be at play, if possible, we can make some headway. But it's tough. And that's why I'm so keen on that being sort of my next, well, the big thing for me to kind of try and unravel is, if I can, is some of that with colleagues. So it's just, we just don't know a whole lot about it.
Yeah. Well, I'm excited for that to come out eventually and see what it says.
Yeah, we'll see. Yeah. You and me both.
So going back to the review, I guess my big picture interpretation, and tell me if you'd agree or disagree, is that y'all found, improvements in the intervention groups that on average were more beneficial than the comparator, but there's a big caveat of a lot of the lack of fidelity or low fidelity and the not that much or not that great efficacy. So taking this with a grain of salt, but higher fidelity papers and research needs to come out for there to be a stronger like conclusion of whether or not it's recommended. Am I kind of on a good thought process there?
No, you're right. Yeah. And I think the thing for us that we wanted to hammer home is that if we didn't look at fidelity, it would sure look like this treatment should be advocated for as part of a multimodal treatment approach for what we looked at. But then you throw fidelity in there and it's like, oh, well, let's hold on a second. Maybe we need to look at it a little bit more critically, not say one way or the other, yes or no, because I don't think we ever can, but to be cautious about that because of the lack of fidelity that we saw in the papers that we investigated.
Okay. Got it. Do y'all teach at University of Indianapolis taping in your program?
I have thrown it out once or twice. I always tell a story to my students to hit home on the point that, check yourself at the door and your biases and do what is going to be best for the patient. And they may know that I don't have a strong propensity towards K-tape, but I was fortunate enough to be with some of our top athletes as part of the USA medical team in South Korea back in 2015. And one of the rowers was having some elbow pain. And, she was saying that she had, K-tape before and this and that and the other thing, and that it was really helpful and in the moment. So I did some treatment with her, and then sure enough, because she was competing at a high level, I was like, we're gonna do the K-tape if that's what you think helps. And so I took a picture intentionally with her, obviously, but with the K-tape on to show my students that, hey, you know what, even though I don't really think it works, literature may not support that. Here's an athlete in the moment that needed that, or at least, in our opinions, she needed that. And so we put K-tape. So I tell them that story, and then I'll give them like the real basics about it, and then go from there.
So for someone like that, where, it's high level competition, they believe it works, you're going to provide it. We'll stick with the shoulder. Will you apply it? Do you have a process of applying it, or do you apply it willy-nilly? Like, okay, we're new. Go ahead.
No, and I think that was one of the messages I sent to him too, is that, you've got to know your opposition. If not as well as what you're promoting, it may be even better, right? So that you have a way to discuss it at length with people who might have a differing opinion, so that you might come to some understanding together. And so my point is that, you've got to know the different methods to applying it. You've got to know, that you don't just stick it on and, round the corners and create some slits and put it where you think it ought to go. If you're going to spend time doing it, do it properly. So at our university, I don't think we spend the time to do that, that particular treatment. And I don't go into tremendous depth when I talk to them about it. And it's been a couple of years since I have. So yeah, I think there's the process for me in that instance was what worked for you before, and I'll replicate that same method, as opposed to, trying my own method that may not be as effective as your previous one was. And is it effective because she thinks it needs to be effective, or is it really effective? Does it really matter if it's effective? And that's a debate. I mean, that, you could argue either way. But it wasn't my position to come in and say, I don't think this is going to work. Here's what we're going to do. That's me being not a good clinician, I think.
So in a case like that, where if it's more so you are in a private clinic, because I mean, if you're working with athletes in an institution, it's hard to say that, you don't do those things if you're expected to be the one that provides treatment, as opposed to if it's a private clinic and you're like, you respect their wishes, but it's not something you do. So like in that case, where I think the three of us would agree that, we want to promote more like active-based approaches, giving rehab where it fits and works for them, with more of the shared decision-making and education. And then, for me, like, I don't have a problem with doing some of like the adjusting and stuff like that, but it's not what I want to lead with. But if you have somebody who comes in and says, the K-tape is what worked, and you talk to them, you lay out your ideas. It's like, well, we could do that, we could do this, or you could do no treatment, and they're hell bent on the KT tape. Will you still give that spiel of like, you know, kind of XYZ of KT tape? And then if they're still, you know, adamant that that's what they want, will you recommend another clinician, or will you kind of still provide that treatment, even though for you it's not really like what you believe in or what you support? Does that make sense?
Yeah, no. So, and I'll try and answer. I think it depends on the environment, right? So in the case I gave, like, I'm there for a month and I was with the rowers for maybe, you know, a week and change. And so is that really the place for me to lay all that out when I know I'm never going to see that athlete again? Or am I just going to provide what is going to be the best treatment for her to get through this event or this part of, you know, the competition? So that's an easier answer than if I'm a PT ATC and I'm working with a collegiate athletic team, or I'm working with you know, a professional team. I think you've got to realize when you go in there that you're entering an environment where if they don't get what they want, they're going to go to somebody who's going to give it to them, right? And that's maybe not too much different than an outpatient orthopedic clinic, but I'd say it's at a heightened level in that environment. And I know folks that it doesn't take but one or two athletes to not get along with a trainer or a PT. And what do you know? That person doesn't have a job anymore because it's not you who's going out there and making all the money and filling the stands. It's the athlete. And we're there to give the athlete what they need to perform at the level that they need to perform. That conversation, I think, happens with the sports medicine team at a predetermined time that says, we're going to sit down and we're going to talk about the approach of how we're going to treat our athletes in season, out of season, strength and conditioning, what sort of treatments we're going to provide, what's going to be our unified message to the team as a sports medicine team, not as a physical therapist, not as an orthopedic surgeon, not as a trainer, not as a chiropractor. What are we all going to get on board with, and what's going to be our message to the team? How are we going to treat our athletes? I think that's how you navigate those waters, you know, and then it's already figured out, right? And you know kind of what you're getting into. Maybe you don't. It's a whole different ball game. I've seen it. I've been there, and it just wasn't for me. But I think that open communication is key, and I think you got to be careful not to, you know, to get on your high horse and say, well, I know this is what, you know, this is what does work, or this is what doesn't work, when in fact maybe it has worked for them. And who are you to say it doesn't, right? I mean, have you ever met this patient before? Have you ever tried this on that patient? I mean, can't sit on a two-legged stool if we're talking about 3 legs of evidence-based medicine, right? You can't just take one of those out and then put whatever you're putting on top of it and expect it to stand up. It's not going to happen. So that, I think, has been a struggle for me in teaching and when I was in clinic, is to check myself at the door and have enough of an open mind to know what the evidence says and be so passionate about it, but to not let that be the hammer when I go in to have that conversation with the patient. And it doesn't matter what environment you're in with that, I think.
No, it makes a lot of sense.
With the Paul, you mentioned like the shared decision making, you always lay out the option of doing nothing. I don't know if you want to give like a specific example or just talking like broad terms, but like, how many options will you give? Because it feels like it could be endless. Of like, let's say someone's coming in with maybe just rotator cuff related shoulder pain or whatever you want to call it. There's no major like acute event, and it's been just kind of a chronic thing. Will you give like, we could do nothing, we could try a very like generalized upper body exercise program, we should try something specifically to that shoulder, we could try these interventions on top of it? Like, how many layers are you adding to the options that you're giving them? Yeah, and we can go from there.
Yeah, I think you keep it big. Well, I don't say I think you. I think I like to keep it big and broad. Where okay, here's your options. You give the example of rotator cuff related shoulder pain, non-traumatic. Here's your options. You can do nothing, and here's what's likely to happen. You know, you could try conservative treatment with physical therapy, and here's what the evidence says about that. You could get a cortisone injection. Here's what the evidence says about that. Ultimately, you could have a surgical intervention, and here's what the evidence says about that. Right? And then people start to get all nervous and everything and be like, whoa, you're stepping outside your scope of practice. You're talking about other professions and everything. Well, no, I'm well within my wheelhouse, and I'm real comfortable with talking about the literature and what it says, because I'm the advocate for my patient. And if someone hasn't taken the time to explain those things to them, that's going to be me. And I understand you got to be careful about that. And I might be in a little bit different position than some folks, but there is absolutely nothing wrong with discussing various treatment options, even from other healthcare providers, with your patient and what the evidence says about that. And I think in our viewpoint that Jeremy Lewis and I wrote up, you know, he put something in there about to that effect of if, you know, for the people who think we shouldn't be having that conversation, you know, wait a couple of years of what the evidence says, and you'll be wishing that you were having those conversations with your patients, because, and that's just my thoughts on that. And some people might be real uncomfortable with that, and that's fine, because you've got to understand what the evidence says and be willing to have that conversation. And some people, maybe you got to tiptoe a little bit, you know, if you got a relationship with an orthopedic surgeon and so on and so forth. But really, that doesn't change me being interested in helping my patient out. I mean, if you look at subacromial decompression surgery, that shouldn't be happening anymore. No one should have that anymore. There's been placebo surgeries. I mean, it doesn't get much more clear than that. And there's harms that are underreported in the literature that are huge with that type of surgery. So how am I not going to have that conversation with my patient? Sorry, I get a little, yeah.
No, that was great.
Big and broad.
Yeah. Has there been an instance where you've laid it out and the person is still like, yeah, I think I want to get surgery for a surgery that you're explaining isn't that efficacious?
Yeah, that's fine. I mean, yeah, it happens, right? Because somewhere along the way, the narrative has been told to them that there's a structural abnormality and surgery is going to be the only thing that fixes that. Oh, sorry, I missed a piece. That structural abnormality is what's causing the pain and dysfunction, right? And that surgery is going to be the only thing that fixes it. And they've bought into that. So once their mind's made up on that, if you can't have a conversation that changes that narrative in some way, then maybe the only thing that is going to get them better is going to be surgery.
Yeah.
I mean, the mind is a powerful thing. I mean, it's.
In a case like that, though, like if you are dealing with somebody who is leaning more towards more of the invasive procedures, so it could be surgery, or maybe they're looking at like injections, PRP, things like that. And you've kind of laid out what treatment approaches, you know, you would like to perform or that you think would be most advantageous for them. And you're seeing that those things maybe aren't helping. Would you be more open to providing some of those other forms of like passive care or like non-pharmacologic approaches, like in the paper of the KT tape, or because the evidence still doesn't really support the use of those, would you be more open to talking about like injection and surgery if you felt like that was more appropriate at that point in time?
So let me see if I'm understanding your question here. If I felt like one type of treatment was more appropriate for them at the moment, would I advocate for that more, even if it was outside of my scope? Or is that not what you're asking? I might be missing it.
It's more so like in the case that you were kind of talking where somebody has been given the narrative that they, you know, have a structural abnormality and they need surgery.
Yeah.
And like they're just coming in to see you. So you lay out like a treatment plan, you know, where it's like exercise education, things like that. And, you know, you kind of have that discussion of like, these things will probably be more beneficial at this point in time than going down the surgery route. And you do a trial of care for however long you and the patient seem appropriate. And you get to that next evaluation, and you feel like they're still in a place where they're leaning more towards surgery or injections. Would you discuss other like passive approaches or different types of like non-pharmacologic treatment? Or would you now go more into the discussion of like the surgeries or the injections and being more open to that? Does that make sense?
Yeah, I guess. I think in my mind, at that current state, the options I've put out there, and not necessarily, it's not how I feel about them. It's sort of what's the best value-based care based on the evidence and based on what you're bringing to the table in my experience, right? And so if I'm thinking conservative treatment, the patient agrees with that, but then they change their mind and wants to do like a surgical intervention, I don't know that I would change what my conservative treatment looks like just because they're now leaning towards a surgical intervention.
Yeah, and that makes sense.
I wouldn't want to go towards, something that I wouldn't normally go towards just because I think my conservative treatment would be my conservative treatment, period. And not to say that it wouldn't ebb and flow with how the patient's responding, but I wouldn't all of a sudden say, oh crap, they're wanting to go towards surgery. That's a passive approach. Let me see if I can pacify them with some of my passive approaches and lure them in my direction. I don't know that I want to set that trap because it's against what I'm trying to promote, I guess.
Yeah, no, and I absolutely agree. It's just because there's quite a few students and clinicians at like my school who it's, they'll try certain things, and then if it quote unquote doesn't seem like it's working, they'll be like, well, why don't we just do this because, it won't hurt anything, as opposed to like based off of the evidence and like the high value care versus the low value care, like this is how your treatment would look regardless because the evidence supports it. Like what you've experienced supports it. Like you and the patient have agreed on this. Like, I don't think I would undermine that after a certain point of time, just because it doesn't seem like the patient agrees with it anymore.
Yeah. And that's their choice, right? I mean, that's their call. If that's what they want to go towards, that's the thing. We've got to be willing. And I think that's where people have a hard time with this conversation. Well, not some folks have a hard time with this conversation about shared decision-making, is that everybody thinks that anybody who comes to see them in an outpatient PT clinic, I can see you for something. And I've gone through my triage and I've figured out that you're a patient that can benefit from physical therapy. Well, my God, I don't think there's a person in this world who wouldn't benefit from physical therapy, but not is physical therapy what the patient needs. Is physical therapy the most appropriate treatment for that patient at this time? And if we're honest with ourselves, I think we're going to answer no sometimes to that, more often than can this patient benefit from PT. And we've got to be okay with that, just like we would expect any other provider to be okay with that. We're not an exception that we've got some magic wand that we can wave over everybody and they're going to get better at every point in time in their injury of their life or this or that. And I'm not saying everybody can benefit from physical exercise. We get that. But do they need to see somebody else or does there need to be a period of rest or, something outside of us is more appropriate at that point in time? And I don't know that we ask ourselves that question often enough.
Hell yeah. Way to go, Paul. We can transition. We kind of talked about it as well, but this topic of the rotator cuff related shoulder pain, that viewpoint. Side note, I reached out to Jeremy Lewis like a few weeks ago, just asking if he ever wanted to come on. He's like, I'm really sorry. I appreciate the offer, but I'm working 18-hour days. I'm like, Jeremy, what are you doing 18 hours a day? That's a wild work day. Have you ever talked to him about what's going on with Jeremy?
Yeah.
Is he all right?
Yeah. Well, Jeremy's doing good. He and I can share this information because we've just got some notification that we can promote it here in this last week. But Jeremy and Caesar are putting together a textbook called the Shoulder Theory and Practice. So it's a textbook just on the shoulder, edited by him and Caesar. And I was fortunate enough to be asked, along with people a lot smarter than me, to contribute to some of the chapters. And so that's supposed to be coming out in February of 2022. So if anybody's ever written a book and tried to take that on, in addition to being a giant in any field like Jeremy is, it's a lot of work. So he's at a point where he's got to turn down maybe a few more things than he might like to at this point to get some higher priority stuff done. So that's probably why.
Yeah. I mean, I wasn't like upset by it or anything. I just, when he said 18-hour days, I'm working, I'm like, what's going on during those? That's a chaotic day.
Nobody's got to worry about me doing that. No, I'm good. I've got boundaries.
Yeah. The paper one, I'm curious, like, if you have any initial thoughts about it, Paul, since you weren't an author, I guess you can speak from like a outsider's perspective compared to the viewpoint we talked about last time where you and Jeremy were on it. Do you have any disagreements with the paper? Do you like agree with the main theme?
So I think, and maybe, so this is how I read it, and maybe other people read it differently. So it wasn't, well, how do I say it? I don't disagree.
Okay.
I think what they're saying is that, is providing a strengthening program for the shoulder, people who have rotator cuff related shoulder pain, is it helpful? And I think ultimately their answer is yes, but why? And maybe it's different than what we thought, right? Because they mentioned the studies where, this is off the top of my head here that I'm thinking this, I think there was a few mentions of, people get better or their pain reduces, but they don't see any change in strength, right? There's no level of strength differences from when they were hurting versus when they're not hurting anymore, or maybe there's no change in the pattern in quotes of their scapula and this and that. And so then, how is exercise? Maybe exercise has a hypoanalgesic effect, and maybe it's not what we think it is, right? And so that's kind of what I took away from. It's not that strengthening exercises are bad, or strengthening with folks who have rotator cuff related shoulder pain is bad, but why is it working, and why are we seeing it work like it does? And maybe y'all took something a little bit different away from that, but that was kind of my gist.
No, I agree. I think inherently a lot of like strengthening papers, because we see it a lot with the low back, it's inherently something has to be weak, therefore you need to train it, and that's why your back is either in pain or you're not quote unquote functioning well. And I think more so it needs to be that we do see secondary benefits with resistance training, aerobic exercise, things like that, but I think we can get away more with like giving them a program that more likely they're to adhere to and enjoy, so like basing it off of their goals, as opposed to thinking we have to specifically try and isolate like muscles that function on the scapula, or like the traps or things like that, where we see that maybe kinematics aren't changing, strength isn't really changing all that much. So I think instead of getting stuck on specific exercises or weakness, we can take a broader approach and give people more of a generalized idea of why we would promote resistance exercise, as opposed to you're weak and you need to strengthen X, Y, and Z.
Absolutely. And I think, not to downplay that it can be sort of an aha moment, right? Because your prescription of those exercises, if you understand that, then must change, right? It must change. It can't be, we need to hypertrophy those muscles and we're going to do 3 sets of 10 to 15, 80%, of your 1 rep max. And this is not that anybody calculates that or anything in clinic, but like how we go about things then needs to change. And it that paper is going to change how I educate my students. and this is a beautiful example that I'll give to my students of how I expect you to treat patients differently 10 years from now than what I'm telling you, because the evidence is going to change. Here's an example of how I'm changing the way I'm teaching you this semester versus last semester because of this new evidence. So I'm trying to lead by example, right? So I always ask them, what do you hear people give for strengthening exercises of the shoulder? And I go, 3 sets of 10, 2 to 3 times a day. I'm like, put your hands up for anybody who exercises. A bunch of hands go up. How many have exercised every day? A bunch of hands go down. How many have exercised 3 times a day? Nobody's hand stays up. You're young, healthy individuals, and you're not exercising 3 times a day, 3 sets of 10, 12. Why in the world? What principles of strength and conditioning, if that's what you're trying to get at, is telling you that you need to ask your patients to do that? Whether it's for endurance or hypertrophy, that just doesn't jive. But if it's to promote something else, or there's a different effect and it's not hypertrophy and it's not strengthening that we're after, then maybe it still needs to change. But how do we change it then? How does our intervention then change based on this new understanding of, are they really weak? And I think that's one of the great things about this paper, right? It causes you to pause and sort of think about that a little bit more. Because to be honest with you, somebody comes in and says, my shoulder's been bothering me for a week. All right, what were you doing before that? Well, I was in the gym, 3-4 times a week. I'm really active. Do you really think in a week that they've gotten less strong than they were last week? Probably not. There's probably other things that are inhibiting them. Even if you think you found weaknesses on your muscle performance exam, it's probably something other than weakness. And so let's start thinking that way. And I think that's a great narrative to pull off of this paper, and really gets people thinking about how they develop their treatment program for these individuals.
Yeah, I like that a lot. And going back to what I've heard Eric Mira talk about it as well, of like, it's less about the getting stronger. It's more about like the process of like a routine of resistance training or of exercise, of like the potential, all the other variables of they're feeling comfortable working through ranges of motion, they're like getting used to routine, they're increasing like their perceived like autonomy of doing this on their own. And it's like all these other factors related to exercise, as opposed to like the act of, or the actual getting stronger.
Right. And see what you just did there. You remember the earlier in the conversation, we were talking about, one treatment approach versus a multimodal treatment approach. All those things you just mentioned fall under strength and conditioning. So even if you're providing a strength and conditioning sort of approach to treating your patient, you're doing all those things that you just mentioned. So there's layers to that, right? And every individual is going to be influenced by those layers differently, which is so cool. And what makes research super hard to do, to try and pinpoint one thing that's going to be better than another, or is this effective or is that not effective, because it changes with every individual.
True.
Now, in the case of, I'm trying to figure out how to word this, because there are going to be instances where like there truly is pathology and there truly is like weakness. So, because I feel like there's a point in time where people will like read this paper and now everybody thinks, well, if somebody comes in with shoulder pain, like they don't have weakness. And it's like, well, no, like somebody could legitimately have weakness due to like an injury or pathology. So I guess in your exam, because I know previously we talked about that orthopedic testing for these types of conditions aren't necessarily reliable. What would your exam then look like to tease out like true weakness or like true pathology, as opposed to just kind of assuming that somebody comes in with shoulder related pain, that, there is no structural changes or there is really no weakness. There's just other things kind of contributing. Does that make sense?
Yeah, no, I think that's really hard to do. I don't know that we know how to do that. To be honest with you, right? Because let's say let's say you get away from, or let's find a middle ground maybe, instead of testing people's external rotation strength with their arm by their side because they're T, let's ask them to do something functionally, right? And you start to see something that alludes to the fact that, man, that muscle might be weak. And then you try and isolate that muscle in a particular maneuver against resistance, and they can't withstand your resistance as much as they could on the other side. Golly, I don't know. Still, do I really know that it's weakness? I mean, I might ask them, is that painful? And if they say, yeah, that hurts, okay, well, then maybe I know that it's the pain that might be limiting them from providing that resistance. But even if they can't do that, like, how do I truly know if there isn't something else going on there aside from weakness, especially if they were super active and strong and were able to do that just 6 or 7 days ago? What is it that makes them not be able to do it now? In a sense, how are we defining the weakness? But is it like as the muscle atrophied? Is the muscle atrophied and I need to create some hypertrophy? As we all know, the first 4, 6, 8, 10 weeks or whatever of any strength training program is the neuromuscular adaptation. It's not the hypertrophy. That doesn't occur until about like 10 weeks. And so, I don't know that through an evaluation, we can really tease it out. And maybe you guys know better than I do, but I think that's hard. If we really look at the evidence and where we're at right now, we're honest with ourselves. Just because someone can't resist you as much as they can on the other side, that to me doesn't scream they're weak and I need to strengthen them.
Yeah, and I agree, because then the other side of it is, I mean, you're not going to just run to imaging either, because we know that we're going to see, quote unquote, abnormalities, but really it's not abnormal to see like degenerative changes or like tearing in a rotator cuff or things like that. So we can't rely on those either to say that, oh yeah, we have a structural problem. So yeah, right. I don't have a good answer either.
Going off that, so at the clinic I was at, when we had patients with shoulder pain, we did this with most areas of the body, but to get some like objective numbers and data for both ourselves, insurance, and for the patient, we would do like handheld dynamometry. And so we would do like, shoulder flexion, shoulder abduction, and just compare it to the sides. And it was never we never really like explicitly said like your shoulder hurts because it's weak. It was always the discussion of there's a discrepancy between limbs. We can try these strategies to load this area and hopefully get them closer. But now that I like say that, is that also along the same lines of putting in their minds that if I get this number closer to my other arm, it's going to feel better? Because that wasn't like our intention, but it's like there's some, because it's so gray with a lot of this, it provides some level of concrete metrics to work towards and to hope for the best, and to show them like over time that they're improving from a like just a tolerance to force production. Do you know what I'm getting at, Paul?
I smell what you're stepping in, and I think that's cool to think about, like, to objectify things and all that stuff. But, at the end of the day, the patient to see you because they an instrument of pain. But I understand we also need, the point is I would try and make those things can't do, compared to the other side. Well, I can't reach up to this point, or I can't reach above the first shelf in my cabinet, or, I can't grab a full jug of milk out of the fridge, or I can't put my coat on. Those are objective. Those things you can quantify, right? It's either you do it or you don't, or with a certain amount of pain or without a certain amount of pain, or with some adjustment or strategy or without some adjustment or strategy. I like to give folks things like that to work towards, because that's what they're coming to me for, instead of me making up my own game that I want to play for somebody else aside from the patient.
That's a really good point.
And then let that drive my strategy. Let that be the carrot that's dangled in front of them, instead of some arbitrary thing that may not may or may not be linked to theirs as they see it.
Yeah, I would agree.
I'm not saying that's wrong. I mean, don't take me the wrong way. I'm an N of one in all this conversation. We're talking about everything else. I'm just an N of one. And so that's what you should take all this as, is that one little grain of salt.
Yeah, but
on the
it makes a
table.
lot of sense. And I guess like maybe I'm just not well read enough, but really the only big like limb symmetry indexes that have a lot of evidence to support them is like getting, you know, quad LSIs back for post-op return to sport ACL, but then maybe a lot of these other like body parts or regions trying to create inherent like LSIs or symmetry, just there's not enough research to support that that's actually going to like reduce the risk of injury or reduce like perceived pain. And it more so should be based off of their ability to do what they want to do, as opposed to chasing a number or a ratio.
Yeah. And I would look at, you know, at points in time in history in healthcare, like when insurance companies said that we need to objectify things for us to pay you, when did all these outcome measures and everything become so popular? Like, is there some kind of coincidence there? Like, did we do this for not the wrong reasons? Because I think that's not the case, but did we do it more to justify a system, or did we really do it for the benefit of our patients? And like you said, is there evidence then to back up that when something like that improves, their function improves, their pain goes down, they spend less time seeing us? Like, if that's all true, great. But if not, if we're doing it for the wrong reasons, then golly, let's stop jumping through hoops, folks, and let's call it what it is.
Yeah. Do you, based off that, do you, when you were seeing patients in clinic for who had shoulder pain, would you give them outcome measures?
Yeah, see, that's the thing, right? This is me talking out my mouth and my ass at the same time. So I think quick dash fatty, and then, you know, with the frozen shoulder study we're talking about, we use outcome measures to try and get at some of the biopsychosocial stuff, because in inventory we're interested in a lot of those questions. How much difficulty do you have doing this activity? How much difficulty do you have doing that activity? And it's a patient reported outcome measure, right? The patient gets this to say, this is that, or maybe, holy smoke, outcome measure and say, this is what I'm having trouble with, and this is how much trouble I'm having with it, right? So.
Got it.
I mean, there's some of that. There's some of that needs to happen, and that's where, you know, life is about balance, right? I don't care what you're talking about. Life is about balance. You can't swing one end of the pendulum and be healthy. There's got to be a yin and a yang that live together.
Nice, Paul. Derek, do you have any other questions?
I'm
That might have been like
bringing
the
it
perfect
back.
ending point.
Moment of Zen. Yeah, here we
That
go.
was good.
No, I don't have anything else. I thought it was a lot of great discussion and cleared up a lot of things for both papers. So I appreciate you taking the time to do that.
Anytime, gentlemen.
Yeah, thanks, Paul. And appreciate you still being open to do it mid road trip. What a champ.
Anytime.
All right, well, have a safe rest of your drive, and thanks again. This was great.
You got it. Take care, guys. Good
All
luck
right.
on the rest of your clinicals.
Thank you.
Thank you.
Bye.
All right, take care.